morning, Dr. Arun. How are you?
Very nice to see you, ma'am, after 2 months.
Good to see you too. I hope the whole family is doing well.
Yes, ma'am. And also we have Asha Agustin. You will be knowing our regular MC. Asha, can you switch on your camera, please?
Hi, ma'am. Hi.
Hello, Asha. How are you?
I'm good. How are you, ma'am?
I'm fine, thank you. Good to see you.
Good to see you too.
Okay. So, Arun, are we all set? Dr. Arun.
Ma'am, we'll follow the process actually. Flow plan would be remain same. But as we know, we work for African countries maximum. Like we start with our support for Malawi and another 2-3 countries which was flooded actually. So we want to give our prayers to all my friends and sisters, brothers at that country. And then we will start up with our special program for you. Then doctor talk, one more doctor talk, and finally we'll end the program.
Okay.
Ma'am, we'll start in another 7 minutes time. Now, I guess it will be 10:53 in Ghana. So sharp 11 o'clock we'll start, ma'am.
That's okay.
Yeah, now we have got 50 people already, and also it is live on YouTube. So I will also send you the WhatsApp link on your YouTube link on your WhatsApp.
Okay, all right.
Sure, ma'am. Looking great, ma'am. Thanks, ma'am.
Thank you. Thank you so much.
Dr. Suraj Manjunath, surgical oncologist, is also joined. So, yeah.
Good morning and welcome to you all to the 5th session of Mastermedics. Let's start the webinar with a prayer for the people of Malawi, Mozambique, Zambia, Madagascar, who have been affected by the cyclone Freddy. Our support has been for the people of Africa, and we pray for faster recovery of all those who have been affected by the cyclone. Manipal Hospitals Group has always been at the forefront in sharing knowledge among medical fraternity. The knowledge transfer will help in improved quality standards, improved services, better clinical outcomes, and improved patient satisfaction. The aim of the program is to engage referral hospitals at all levels to improve the quality and safety of patients, to improve the quality standards of referral hospitals and patient-centered outcomes, and also to share Manipal Hospital's experience and expertise. This is our 5th program, and we have been able to connect with around 4,000 nurses till date. Before we start the webinar, we would like to felicitate a very special person who doesn't need an introduction. She is a nurse educator and has over 20 years of experience in the health sector of Ghana as a nurse. She has taught and influenced the youth of Ghana to become nurses and midwives. She holds a master's of public health and a bachelor of arts degree in nursing with psychology from the University of Ghana. And a postgraduate diploma in education from University of Cape Coast. She's also a certified pensions trustee licensed by the National Pensions Regulatory Authority of Ghana and sits as a member secretary of the Board of Trustees of the Healthcare Occupational Pension Scheme. She is a foundation fellow of the Ghana College of Nurses and Midwives and a fellow of the West African College of Nurses and Midwives. She is also a member of Sigma Theta Tau, International Honor Society of Nursing. She is none other than Ms. Madam Perpetual Ofori, President of Ghana Registered Nurses and Midwives Association. Manipal Hospitals, commemorating Women's Day, we would like to felicitate Madam Perpetual Ofori for her remarkable work in the field of nursing, and also for her strong faith and support in the Mastermedics program. She has been an inspiration, guide, and a teacher for all in Ghana, Africa, and the pillar of the Mastermedics program as well. Manipal Hospitals India would like to honor Madam by offering the certificate of appreciation from Manipal Hospitals India. May I request Dr. Suraj Manjunath, surgical oncologist, Manipal Hospitals, to do the honor. Over to you, Dr. Suraj.
So, Perpetual, it is indeed an honor and a privilege to come across people like you, who are so inspiring to the world at large, and especially on, this being part of the event for the Women's Day. It is really my privilege to award you with this certification from our side. I wish you continue your inspiring work and inspire many more women to rise up and come up in this world and do what you have been doing for the world at large. Thank you so much.
Thank you. Thank you so much, Dr. Suraj.
Asha, once again, Doctor, just I want to tell you some few pointers. Because of ma'am, we are able to touch around 5,000 nurses in Africa. Because she has so much of connect that we are able to, we have a solid database of 5,000 people. Not only in Ghana, it is in Kenya, Nigeria, and also she represents the African nursing community. So we are very thankful to her because we started this campaign just 1 year before where the numbers were around 100 to 200. Today, we have reached around 5,000 nurses. So it is like not small number. Training 5,000 nurses is a very, this one. So it is all the background and the brainchild behind ma'am's support actually. And she has been very encouraging, doctor. So, and also, ma'am, Dr. Suraj Manjunath is one of the veteran in surgical onco, and he's been the veteran in our cancer department. And so I thought the better person than him, than no one else for this beautiful occasion, ma'am.
Yeah, really nice to hear this so much. Since you are at the forefront and you're leading so many women, just one request from my side. If whenever you have time, if you can spread the awareness about cancer as well in women, especially breast cancer and cervical cancer. These are what are, the important cancers affecting women now. So a simple self-examination of the breast is one thing that I request you to spread the word. Once a month, just examine, every woman examine your breast just after your periods. That itself, that alone will go a long way in detecting cancer early, where we can cure them and treat them and cure them completely. Thank you very much.
Thank you, Dr. Suraj, and thanks, Arun. May I now invite Madam Perpetual Lafori, President of Ghana Registered Nurses and Midwives Association, to address the delegates. Over to you.
Good morning from Ghana, and I bring you very warm greetings from all nurses and midwives in the country. It's a privilege for me to be invited and honored in such a special way by Manipal Hospitals. I want to use the opportunity to say a big thank you to you and to all my comrades in Ghana. A big thank you to all of them. Whatever I've been able to achieve, I wouldn't have been able to do it if I didn't have the support of my other colleagues and of course the entire membership of the association. So I thank them all, and I'm very grateful to Manipal Hospitals for this award. Indeed, I'm very grateful. Thank you very much. The issues about the disasters you mentioned, we want to add our voice to say that we are with all of them in spirit, Malawi and all the other countries, and we hope and pray that they are able to get out of this. And I want to say that we had the opportunity of holding our International Women's Day. We commemorated it on the 15th of this month, and we centered the discussion on cervical cancer. So I want to assure Doc that it's a work in progress, and we want to campaign seriously on the issue of having vaccination, women getting vaccinated against cervical cancer. And of course, we cannot also leave the issues of breast cancer out, and we will continue to work with our partners, both locally and internationally, to draw the attention of our society to the issues and how we can prevent it, and also proper management and care. Thank you very much for this opportunity.
Thank you so much, Madam. We will now have, we have two sessions.
Asha, we'll start with Shiny. Shiny is already there. Yeah.
We have two sessions for today's mastermedics program. The first one is Advanced and Safe Infusion Standards in Nursing, which is by Shiny Verghese, Head of Nursing, Manipal Hospitals. And we also have another second session, which is Advanced Cardiovascular Support, which is by Dr. Samanjoy Mukherjee, Consultant Senior Interventional Cardiologist, Cardiac Sciences, Manipal Hospitals, India. So I would now request Ms. Shiny Verghese, Nursing Head, to present on Advanced and Safe Infusion Standards in Nursing. Over to you, Shiny.
Hello. Am I audible?
It's audible, Shiny. Yes.
Okay. Very good morning to everyone, and very hearty congratulations to Madam Perpetual for this occasion. So nice to see you being facilitated. Very nice. Thank you for inviting me here and having me here for this talk. An infusion is said to be safe when it doesn't cause harm to the patients, provider, or to the environment. Infusion safety is achieved by using sterile techniques, sterile devices, discarding of the used devices to a puncture-proof container in a safe manner. Any breach in these above procedure would lead to an unsafe practice. WHO proposes 1 needle, 1 injection. That means there is no chance for a reuse of the needle or syringe. The risk of harming the patients can be avoided by having the procedure done by a qualified personnel who has the skill to do it, using this 1 needle, 1 syringe motto, and securing the correct device and the site for the injections. Peripherally inserted intravenous cannulation, of course, it is an essential skill for a nurse to succeed. So let me pull out my presentation.
We can see your screen, Shane.
Okay, right. Yeah. So we will be going to talk about the components of safe practice infusion therapy, and how to select the right vascular access device and the site, indication of short peripheral catheters, and care and management of devices, therapy considerations, and VIP scores, visual infiltration scores, and access and manage complication, and a few easy tips and to take a challenge. These are the way we will be talking. Okay, is it in the slide share model? Yeah. Now, components of the infusion therapy. We all know that first and foremost is the hand hygiene. So we must follow this 5 moments and 6 steps of the hand hygiene. I hope every one of us are aware of this. What are the 5 moments of the hand hygiene? It is 2 before and 3 after. 2 before means before touching the patients, before doing a procedure, then after being exposed to the patient and the patient environment, and after being exposed to the surrounding and exposed to the blood and body fluids. Yes. And what are the 6 steps of the hand hygiene? I am sure all of us know about it, and it is better to practice it once, right? That is the simplest, safest, easiest way to protect the patient and ensure the safety. And that is the simplest way to prevent the infections. Can we practice it once? Yeah. Palm to palm. Dorsum left over the right, and the vice versa. And interlacing, interlocking, right? And tip of the fingers and the thumb rotation. Okay, great. A thumbs up for all of you if you have done it. Okay. And next, following to the hand hygiene is the site preparation. And perform the skin aseptic technique, right? Use the chlorhexidine in alcohol, 0.5% chlorhexidine in alcohol solution. The chlorhexidine, 70% of alcohol can be used. When after preparing the site, before preparing the site selection need to be considered. We must always avoid the fractured, injured site, or a paralyzed site, or a site which has an AV fistula, and also a site which has a mastectomy done, the side where the mastectomy done. Use the non-dominant hand, because the dominant hand, the patient will be using it for several occasions. So as much as possible to avoid the dominant hand and use the non-dominant hand. And aseptic, next comes the aseptic technique of the insertion of the cannulas. Remember the aseptic non-touch technique, because it is a tendency that once we prepare it, we felt it, we prepare the hand, prepare the site, and then we feel it touching it once again, right? Yeah, so that has to be avoided. So you can remember this technique, and it is aseptic non-touch technique. So it has to be, we have to avoid the key site and key parts of the device. It should never be touched, right? The key site and the key parts should never be touched. And then comes to the sterile dressing. Perform the dressing changes on short peripheral catheters when the dressing becomes damp, loosened, or visibly soiled, and at least every 72 to 96 hours. Then comes to the flushing. Single-use flush device. Flush all vascular access devices with a preservative-free 0.9 sodium chloride. Use a minimum of 5 ml in order to get the catheter cleared. And then scrub the hub. Perform a vigorous mechanical scrub or a manual disinfection on the needleless connector prior to each vascular access device's access, and allow it to dry. Or use the chlorohexidine impregnated caps if the alcohol swab is not available. It is an alternative solution, alternative method to make the hub sterile. Okay, and also we need to monitor the phlebitis rates related to peripheral catheters using a consistent, standard and clinically feasible calculation, which may be reported as a phlebitis rate based on point of prevalence of peripheral short catheters. So how the phlebitis is calculated is by the number of phlebitis incident occurred in that month divided by total number of peripheral catheters used in that month into 100. That will give us the percentage of the peripheral phlebitis. So please remember the component of the safe infusion therapy. It is the hand hygiene, the site selection, site preparation, aseptic technique, the sterile dressing, flushing, and the management of the hub area. Right. Moving on to the right vascular devices. How can we select the right vascular devices and the site? According to the Infusion Nurses Society, the correct vascular access device choice is based on the patient history, physical examination, diagnosis, type and length of therapy, and available nursing skill to practice and maintain the devices. The vascular access devices is selected is of the smallest outer diameter with the fewest number of lumens and is the least invasive devices needed for the prescribed therapy. Peripheral vein preservation is considered when planning for the vascular access, and safely engineered devices are selected and consistently activated and used. And it has the greatest likelihood of surviving anticipated length of therapy and accommodates therapy requirements, is the least invasive, utilizes the fewest number of catheters, and meets the benefit versus risk assessment. And select the right vascular access device. Continue. When we consider the infusate characteristic in conjunction with the anticipated duration of infusion therapy, if it is less than 6 days and availability of peripheral vascular access sites, then we will be selecting a short peripheral catheter. And do not use the peripheral catheters for continuous vesicant therapy like chemotherapy and parenteral nutrition, and infusate with an osmolality greater than higher 900 osmolality per liters. Then we cannot take a peripheral vascular access device. And then the second consideration is select the smallest gauge peripheral catheter that will accommodate the prescribed therapy and the patient need. Consider a 20 to 24 gauge catheter for most infusion therapies. Peripheral catheters larger than 20 gauge are more likely to cause phlebitis. Consider 20 to 24 gauge catheter for neonates, pediatric patients, and or older adults to minimize the
So, Saini, your voice is not audible. Ma'am, I guess there is a network connection with Shiny. We'll start with Dr. Samanjay Mukherjee. Oh, Shiny is back.
Yeah, I'm sorry about that. I don't know what happened. So, yeah, as a principle, always use this. Hello, Arun?
You share the screen, no?
Once again, okay. Can you see it? Hello?
Your screen is not visible, Shiny.
Okay, sorry. Can you see it now?
Yeah, now it is visible.
Okay. All right, yeah. Sorry about that. Okay, I was telling, as a principle, always use the smallest gauge and shortest catheter length for the appropriate, it will be appropriate for the therapy. And select the right side. Optimal vein condition will be a soft, straight, elastic, and springy, easy palpated, non-visible valves supported by intact elastic skin, and it is easily stabilized. Ideal site for short peripheral catheters are metacarpal, basilic, and cephalic. These are the sites, and it is common. It is this way for everyone. An indication for an infusion, it is to maintain or replace the body waters, electrolytes, and nutrition in patients who cannot maintain the adequate intake by mouth. And it to restore the acid-base balance, replenish the blood volume and administer the blood component, administer continuous or intermittent medications, administer intravenous anesthetics, monitor hemodynamic function, maintain patent vascular access in a case of emergency, or even in managing the pain. Moving to the care and management of the devices, always see that we assess the line. Assess the line at least once in every 4 hours, and in case of critically ill, every 1 to 2 hours. And assess the need of the devices and remove the extra lines, as many lines increases the chance of infection. Once the patient is stable, no longer require an IV catheter to be in place, then it is better to remove it. Comes to the use of needleless connectors. Needleless connectors are primary purpose of needle connectors is to protect the healthcare workers from the needle stick injuries, and it also reduces the catheter manipulation so that the indwelling of the catheter can be ensured for a longer period of time. Scrub the hub. We have also discussed it in the earlier slide. Vigorous mechanical scrub for the manual disinfection of the needleless connector prior to the vascular access device access, and allow it to dry. At least 15 seconds seconds need to be scrubbed, and this can be replaced in case if you get a chlorohexidine impregnated cap. And the flushing. Flushing is in order to ensure that the line is clog free. It is freely accessible and there is no occlusion there or no infiltration there. Like always remember to use a push, pause, push technique or a pulsatile technique in order to do the flushing. And as we all of us are aware of the importance of the documentation, yes, while on insertion, while assessment and while removal of the line also we need to document it clearly. Going on to the therapy consideration, we need to consider the therapy. Why are we starting a line? Why are we doing? What is the purpose of this infusion? And what is the pH of this fluid? What is the concentration? Whether this is a precipitate, what are the precipitates and particulates, whether it is there? And what is this antibiotic? Whether it is high concentrated antibiotic, whether it is for the nutrition therapy or sourced by too high or low pH infusate can be minimized by further diluting the solution, infusing at a slower rate using a larger vein or a central venous catheter than a peripheral IV. Now, when we go to the visual infusion phlebitis score, which is also known as VIP score, right? So, visual infusion phlebitis score is to identify the complications at the earliest. As we know that the score has 5 ratings. IV situs appears healthy, means it doesn't have any score. It is a score 0. And the score said to be 1 when one of the following is evident, like slight pain near the IV site or a slight redness near the IV site. If it is score 2, then 2 of the following are evident, like it is the pain near the IV site, there is redness, there is swelling. And then if the score is, when the score is 3, all of the following is evident. Pain in the IV cannula site, there is induration, there is redness, then it is said to be 3. And if the score is to be 4, all of the following are evident in an extensive manner. Pain along the path of cannula, there is redness, there is erythema, induction, and there is also a palpable venous cord. All of the above, and plus the fever also is present, then it is the score will be 5. So we need to actually address it then and there. That is why we need to assess it at every 4 hours, so that to see that whether the patient is getting on to the complication. Right. So when we find that there is on any of these symptoms prevailing, then we need to see that we need to stop the infusion and reside the cannula. We cannot going on continuing the therapy when it is infiltrated, when the score is high. Okay. Right. So it is at this time, it is better to also discuss about few of the IV complication. There are local complications available and there is also systemic complications available, and it can be quite fatal as well. So speaking about the local complication, as we said, the phlebitis or the thrombophlebitis, it is the infiltration, extravasation and thrombosis. Moving to the systemic complication, there will be an embolism, right? That could be a pulmonary embolism or an air embolism, or some of the catheter part may be getting dislodged, and that also could cause an emboli. Then it could be hematoma, systemic infection, circulatory overload, allergic reaction, and speed stroke as well. So when a complication comes, let us see what we're supposed to be doing. What are the nursing intervention in order to prevent this? So infusion-related phlebitis happen due to the chemical properties of the infusate. Like we have seen the pH and osmolality and the precipitate of the infusion. If it is higher, then there would be a chance of the phlebitis. Then it also can be infection-related. So phlebitis happen due to an infection, like the catheter tip, catheter hub are contaminated, infusate is infused. It could be an infection-related phlebitis. Then a mechanical related, like phlebitis happen due to the catheter material or vein cannula ratio, like a large bore cannula put into a small vein, then that could happen, right? Phlebitis happen because of the poor vein cannula ratio and also dislodging of the catheter. Then go to the infiltration. It occurs, infusate enters the subcutaneous tissues rather than the vein. And extravasation, infusate comes out of the endothelial lining of the lining and accumulates under the surrounding tissues and causing tissue necrosis. So what we need to do with that, the dilution of the infusate, setting the rate low, and also preferably to select a large vein and a smaller catheter when we take, these complications can be avoided. And coming to the infection-related phlebitis, aseptic technique, that is what we require. Aseptic technique, hand hygiene, and ANTT we have seen, and dressing, the sterile dressing, and the sterile handling of the site can also prevent the infection-related phlebitis. And catheter material and vein cannula ratio, we need to be carefully selected in order to avoid the mechanical related phlebitis. And infiltration, early recognition of the infiltration, and we need to tape the cannula securely. We should not have the the cannula loosely done. And patient education is a key factor. We need to tell the patient that when all this when these symptoms occurs, they need to tell us, right? And involving the patient in the care is the best way of addressing any complications. And in case of extravasation, using a small catheter over a large vein if possible, an appropriate dilution of the medication and slower rate, and the line monitoring also is essential. Some of the prevention tips of these complications are opting an accurate device or the site, complete preparation of the site and allow it to dry. And always remember the ANTT. Transparent dressing will give a chance to pick up complication at the earliest. If it is soil, the wound, the dressing is soil, remove them at once, as it would cause again the germ to grow there, harbor there. And the flushing technique, push, pause to avoid exertion to the site. Device change guidelines need to be observed. Observe the signs of complication. Even at the slightest symptoms occurs, we need to pay attention. And remember, in case of pediatric cases, the bandage applied should not be too tight around the splints, right? That also will cause the lot of complications and appropriate dilution of the. And whenever we identified a complication, remove the devices immediately and also resite it. And even a few easy tips in order to follow. I know most of you would be veterans in the field of cannulation, but if there is any novice is there, or if you need a little more experience and practice, let me tell you, stay focused and be prepared. You and your patient should always be composed. As nervous and rushed we may appear, it will result in a failure. So we need to stay focused and be prepared. And then we should exude confidence, believe in ourselves, reassure the patient to know that you are what you're doing, and that when you have the confidence, patients will know, oh, she knows or he knows what he is doing. And then the patient should be encouraged by your confidence, and of course they will be able to participate with you. And assess for the needle phobia. Some of the patients may have the fear because of the past failures, past failed insertion they may would have had. Okay, and then observe the infection control measures. Intravenous insertion is the invasive procedure and require aseptic technique and proper infection control measures. Wipe a cotton swab or an alcohol pad on the insertion site to minimize the microorganism in the area, and also to visualize the chosen vein more clearly. Assess the vein before inserting the vein needle. into the patient's vein, you have to assess the condition first. A well-hydrated person has firm, supple, and easy to reach veins. Feel rather than look. It's also an excellent opportunity to familiarize yourself with a suitable vein. A tendon may feel like a vein, but palpating through a range of motion may prove it is not. Use an appropriate cannula site. The smaller the gauge number, the larger the diameter of the lumen. The larger the gauge number, the smaller the diameter of the lumen. That we need to remember all the time. Consider the use, what purpose for which it is used. Put into consideration type of the infusion that is needed when you choose the cannula. Needless, with smaller gauge, you could not accommodate blood transfusion or parenteral nutrition. Insert at a non-dominant hand first, that we have again discussed. And the vein selection, always start with the distal vein and work upward. Right, and use a BP cuff rather than a tourniquet, because if a patient has a low BP, it would be the best use to BP cuff inflated to appropriate the pressure to make the vein dilated. And apply the tourniquet correctly. Apply the tourniquet snugly around 20 to 25 centimeters above the, or 2 finger width above the needle insertion site. Feel the radial pulse with the tourniquet in place. If you can't palpate it, then that means that the tourniquet is tied very tightly. That is not very good. And gravity is your friend. Gravity makes it visible. Gravity slows venous return and distends the veins. Full and distended veins are easier to palpate and are always an excellent option for insertion. And use an appropriate sized needle. Do not let unsuccessful attempts haunt you. Don't be discouraged. Be confident with the next attempt. If given the opportunity, attempt every IV if you can. The more you try, the more skilled you will become. Having said all this, we are at the patient side. So let us take a challenge that we will always select the right device. We will always select the right site. We will take the right dressing, monitor the site. We will monitor the site for complication. We have to, it should come from within, right? That I will always monitor the site for complication so that early detection can prevent the complication. And when in doubt, we will not doubt to seek help, right? When in doubt, we need to seek the help and assess the necessity of the line being there. If it is no longer needed, straight away remove it and do no harm, right? Our patients are already in pain. They are so much in tension. So we should not add any more harm because of our improper technique of handling this IV, and make it a positive experience for our patients. Like every cannulation actually can make or break the image of the hospital, right? Even after a surgery, they will come back for review with a healed wound. But even after the incision site is dried, also some patients may still be having the walking around with the pain in their hands. So we have to see that we will have to make this cannulation a very positive experience. That is about it. Thank you very much. Thank you for your patient listening. Thank you.
Aini, thanks. Start answering the questions in Q&A session, no?
Okay.
Yeah, please. And also majority wants your slides. So you can also try to send across slides to them.
Sure.
Asha, we can start with Dr. Samanjay Mukherjee, please. Yeah.
Okay, we'll start with Dr. Samanjay.
Asha, introduce doctor to audience, no? In doctor, so that doctor can start.
Yeah. Just give me a minute. Our next speaker is Dr.
Yeah, so it's evening here. Good evening. Jambo, Hakuna Matata. So it's like I'm going to speak. I was asked to speak about interventions in cardiology. So I'll restrict myself to coronary interventions. And moreover, we do this.
Doctor, hello.
I think there's a network connection. Meanwhile, I'll just try introducing Dr. Mukherjee to all of you. Dr. Samanjoy Mukherjee is a consultant, senior interventional cardiologist. He has nearly 3+ decades of experience in cardiac field. He has a whole lot of experience in complex coronary angioplasties, especially left main and bifurcation lesions, rotablation, and chronic total occlusion. He is well versed in balloon mitral valvotomy, device closure of septal defects, peripheral and carotid interventions, electrophysiology, and radiofrequency ablations, pacemaker implantations, and CRT as well. He has been actively involved in stem cell research and performed the first study of autologous stem cell therapy in non-ischemic dilated cardiomyopathy as well. So I would now request Dr. Samanjoy Mukherjee, consultant senior interventional cardiologist, Manipal Hospitals, India, to present on advanced cardiovascular support. Over to you, Dr. Samanjoy.
Doctor, before you start, we have Madam Parpil. She is the president of Ghana Nursing Association, and she has been the brainchild of doing this Master Medics program across Africa. She is on the part of the panel today. I thought I would just introduce you.
Right. So, good evening. And I was asked to speak about the advancements and the various procedures that we do at the cath lab in intervention cardiology. And what is intervention cardiology? It's a very important field of cardiology these days, because most of the treatments earlier, which were done with an operation, with a surgery, are now done with just a small puncture in the vessel and going through a tube retrogradely into the heart and managing most of the problems. Of course, there is a role of surgery. Everything cannot be managed with interventions, but majority of the things are being done these days. Now we have a lot of challenges with this. It looks like, it's a very simple thing. There is a deposit of fatty tissue or the cholesterol in the vessel, and I'll show you how it looks in an angiogram. And all that we need to is get rid of it. So we just take a wire across it and inflate a balloon and squeeze the whole fatty tissue and then put a stent to keep the vessel patent. But sometimes it is just like going through a rocky tunnel, as if you are in a tunnel, and we draw a comparison of a tunnel which is actually closed, and there are multiple rugosities protruding into the tunnel, and that is exactly how the vessel looks when we go in. So it is for us to prepare the vessel, but prior to that, I would like to tell you how we go about it. It is either done through a radial access. We have the radial artery, feel the radial artery, and we just put a tube in this, and we can go right up to the heart. Second, of course, is the groin, which was the traditional thing. But the problem with the groin is that they're predisposed to much more complications, bleeding complications. And somebody, of course, nowadays we have devices that when we take the sheath out, we are able to close the puncture with a device. But this is again expensive, and it adds almost about $500 to even $500 to the whole cost of procedure. So to cut it short, we try compressing the vessel. We just compress the vessel, and once the bleeding stops, we are able to just put a bandage over it, a tight bandage over it. Now it is very important because all these procedures are done under heparinization, because we need anticoagulation. Otherwise, any metal or anything that goes into the vessel and comes in contact with the blood, it starts clotting. So to prevent this, we have to give heparin. Usually we give 2,500 to something around 10,000 units of heparin. Very simple. It is about 100 units per kg body weight. So for a 100 kilo person, we need about 10,000 units. For a 75 kilo person, we need about 7,500. But again, we monitor something called the activated clotting time to gauge the anticoagulation from time to time, from almost maybe every half an hour or so. We keep assessing the activated clotting time. That is done just in the laboratory and where we are performing the procedure. And the patients are also given antiplatelet drugs in the form of aspirin, which is given about 100 milligrams, 75 milligrams, 100 or 150 milligrams maximum. And another antiplatelet drug, which is either clopidogrel or a new drug, which is called ticagrelor, or there is another third drug called prasugrel. These three things are given. And usually we give it for a period of 1 year. So one has to be very, very careful because all these blood thinners can lead to excessive bleeding. So the procedure has to be monitored. And it is very, very important for the nurses who are assisting us to have an eye on the monitor, which shows the pressures and also shows the blood pressure and the heart rate. Now, because these procedures, they look quite innocuous, but they're very, very risky procedures. If you just think about that, you're blindly going and just seeing on the monitor and you're not following it. It's not like surgery. Surgery, everything is opened and you have it in front of your eyes. You can always close if there is a leak somewhere. But here you are just going through the vessel and you're going with the catheter with a wire. And of course, there are some quite high-tech devices that I'll be showing, something called the rotablator, or I'll show you even we go with lasers, which can actually cause a lot of injury. It can actually perforate a vessel. And if a vessel in the heart perforates, the person dies immediately unless it is, the bleeding is stopped. So the bleeding cannot be stopped with compression. It cannot be stitched. So all that we have to do is blindly through the vessel. So that requires a lot of precision. So this is how a vessel would look inside. If you look, when I show you the actual pictures of the vessel, how it looks, it just looks like the one that I'm showing you, a rugged inside. And we need to clear it up. As you see, the workers doing it here. And then we want it to be absolutely clean before we want to put the stent and come out. And this is how the highway looks. If you want to park your car inside it, it has to be smoothed out. We have a lot of devices to do this, like a chisel and a hammer, as you can see, and a spade. And from there to the other extent, a drill. And if nothing works, we need to explode inside. So there are certain devices, the laser, which gives current and just burns the whole thing out. Or we have another technology called the lithotripsy, which gives shock waves and breaks the lesion, breaks the calcium also, and makes way. So what we have today is a balloon. The balloon looks exactly like this. There are plain balloons or balloons.
We cannot see your PPT, doctor, actually.
You cannot see me?
Yeah, you cannot see your presentation.
You cannot see my presentation?
Yeah, doctor.
I've uploaded that. Just a minute. Now, can you see? Share screen. Okay. Share the screen. Can you see my presentation now?
No, doctor.
Now?
No, doctor, we cannot see you.
Oh my God. Just a minute. Videos there. Share the screen. Now?
Yes, doctor, we can see your screen now. Yeah.
Okay. Fine. You couldn't see the previous ones that I was talking
correct,
about.
doctor. You can just run through one so that everyone.
I will run through once. Okay. So I've spoken everything now. I'll just go to my presentation. I'll just go to the slideshow. Just a minute. So I would just, yeah. So as the vessel I was talking about, it looks exactly like this inside, with all the blockages. These are all like cholesterol deposits inside the vessel. And we need to clean it up, as I am showing in the other picture, the second one, to make it smoothened like this so that we can go in with the stent and park the stent inside. I mean, implant the stent and come out, and the vessel should look like this, clean, so that you can just drive through and the blood flows through it normally. And of course, to attain this, we have crude instruments like the chisel and hammer, or we have also the drills, as you see, a large bore drill. Nothing works, then you explode. You cause explosions to make your way through. You can use the lithotripsy, which is a shock wave, or you can use the laser. This is the balloon, how it looks like. This goes into the heart, it goes across the blockage, and then we gradually expand the balloon. So we inflate the balloon, and we have inside normal saline 50% and 50% of radio opaque contrast. So these two are combined, and it gradually, it starts expanding inside, and it crushes the deposits to the side of the wall. Now, the special balloon that I'm showing here, this has got blades, so it can make cuts also. So if the vessels, the deposits become so hard that they are just like a stone, so we need these to cut, and it gives a cut, and after that, the vessel opens up, the blockage goes away, and we're able to go in and put the stent. This is another kind of balloon which has got, again, you can see the wire which is wound around the balloon. And once we go and expand the balloon, this wire actually does the cutting. And the other one is the normal balloon. And you cannot imagine what pressures the vessels can sustain, amount of pressures. Normally a car tire has about 30 psi, which is equivalent to just 2 atmospheres. 15 atmospheres is 1 psi. 15 psi is 1 atmosphere. And we go up to, you won't believe, 40 to 50 atmospheres. That is the pressure an artery can withstand. Unimaginable. This is the other device that I was talking of. This is called the rotational atherectomy device. So you can see the diamond studs in the olive-shaped structure. That is what we call as the burr. And this goes into the vessel, and these diamond studs actually cut through the vessel wall with the calcium deposits and the cholesterol, and it pulverizes into microparticles, which is washed away with the blood. There are two kinds. This is called the rotational. The other one is the orbital. So that is like one goes in like this, and another just goes in one plane only. So these are the two very, very important devices that we frequently use to get rid of the blockages. That is not amenable to balloon, because the balloons have a limitation. When the balloons cannot break or make way for the lesions, then we have to use these devices. These are highly risky devices and needs very, very skilled persons to handle them, because it's after all a metallic thing which is just going round and round inside the vessel with a RPM of 160,000 RPMs rotations. 160,000, that is pretty large. The other one, of course, the other device that I'm showing, that goes at 180 to 120 RPMs, rotations per minute. So with this, if you are not careful, you can actually completely rupture the vessel, and the patient dies on the table immediately. There is no way you can save him. Only thing is that you can just put a catheter to drain the blood. In the meantime, you prepare to put covered stent to stop the bleeding, or else you have to immediately rush the patient to the OT for operation. Otherwise, if he keeps on bleeding from that vessel, the blood collects around the heart, and it causes a tamponade, which we call as a cardiac tamponade. This is the safest technology that we have today, IVL. It is called intravascular lithotripsy. So whenever we have lesions which are not giving way to balloon, then we take this specialized balloon, which has got certain sensors inside, and they radiate shock waves. And these shock waves go and break the lesions and cause the lesions to disappear. And after that, we can go and put the stent. So these are very safe devices. The laser is again a very, again, a dangerous device in the sense that we use the laser as a last resort when none of these are working. And this will actually burn your way through the lasers actually burn the particles, the cholesterol deposits and the calcium particles, and make way. So finally, we follow an algorithm of what to use when, depending upon what we see. And this is the common algorithm that is followed worldwide today. Whether to go with a balloon, whether to go with a cutting balloon, or to go with a rotablation or an orbital atherectomy or a lithotripsy and laser. This is how a stent looks inside the vessel. And you can see the balloon is expanding, how it expands. And then you have the stent crimped over it and how the stent expands and holds the vessel open. This is how the lithotripsy works. You can see the lithotripsy atherectomy. That is how it bursts. It just drills through the calcium inside. The other one is the balloon, how it looks. And this is a specialized balloon. You can see it gives impulses, shockwave impulses, and it breaks all the calcium and all the deposits and cleans up the vessel completely. And after that, we just go and put the stent. And normally you can see that dial, and that is the pressure. So you can see we go up to 4 atmospheres, and after we have done all the pulses and the vessel opens up, we just expand the balloon to 6 atmospheres and bring it out. But if we have to do with only the balloon, not this balloon, the normal balloon, then we can go up to maybe 15 or 20 atmospheres. And if things don't crack, then of course we use the specialized balloon, which is called the NC balloons, non-compliant balloons. So with that, we go up to 50 atmospheres, 40 atmospheres, 50 atmospheres. Anyway, these are the different studies which compare the different methods and give us a comparison of which is the safest and which has the best outcome. These are all debatable, but yes, the commonest, because cost of an IVL is almost 3 times the cost of a normal procedure. So again, we have to always keep in mind the cost, and we have to use it very judiciously to prevent overcharging the patients. Now, these are the different trial results. Now, there is again a new technology that has come up now, which is called the intravascular ultrasound. Because many of the things that we see in the angiogram, that you can see the angiogram here, the black dark structure that you see, that's the vessel. And wherever you find thinning, that is where the deposits are. But sometimes we're not able to assess the kind of lesion that we are finding in the angiography. So we take help of 2 technologies. One is intravascular ultrasound, and the other is optical coherence tomography. So this gives a better idea about the vessels, and we see the vessel better from inside. It is like this is an optical coherence tomography. So this is a catheter which goes in, it's just like a camera, and it takes the pictures within the vessel. And the other, of course, that I was showing was, this is the ultrasound, sorry, this is the ultrasound. So these are the 2 methods by which we can also assess the blockages, and you can see how the blockages look from inside, and you can see the big thick deposit of cholesterol and the cap over it. This is a very beautiful picture taken by an OCT. And this is how the blockages look. And when we put the IVL balloon and give shock waves, the calcium and the structure side, where you can see those cracks coming up, and then they are pushed back, and we get a full nice vessel diameter. So this is again the angiography that I'll show you how it looks. And when we do this angiography, you can see the multiple blockages that a person has in terms of the narrowings that you see in the dark lines. The thick lines are the normal ones, and the thinned out ones are the blockages. And this is one of my patients with very heavy calcium, and he was refused bypass surgery because of his lung condition. He had very bad lungs and something called a porcelain aorta, where the whole aorta is calcified. So if the whole aorta is calcified, you cannot punch holes in the aorta and take grafts, because none of the stitches would go in and hold. So in this case, he had only one option, that was an angioplasty. And anyway, I could not judge it from the angio film that was shown to me initially. And when I took him up, I found that he has extensive calcium, and this would not give way to a normal procedure of angioplasty with a balloon. So in this case, finally, I decided that I will go ahead and do a rotablation. And this is what you see, the black line that you see here. This is actually the catheter of a pacemaker. This is a temporary pacemaker that we put. And after that, because as I mentioned, that the nurses have to keep an eye on the blood pressure as well as the heart rate. So when the heart rate drops below a certain critical level, say less than 60, the pacemaker takes over and starts pacing the heart so that the heart rate is maintained. Now this is what you see is you'll find the dark thing moving. That is the rotablator. It is drilling through the calcium, drilling through the vessel obstruction and going in. And it is rotating at a speed of 160 RPM, rotations per minute. And you can see how beautifully it cuts through the calcium and it goes in now. Nicely it goes in. That's how it cuts. And finally, we polish it off. Finally, we can see it polishing up, going even further down now. Now it's going in beautifully, cutting through all the calcium that is there. And after we have done this, we take a picture. It looks, the path is better, but of course not fully opened up. So now we take a balloon, and this is how you can see the two dots there. You can see the two dots. You can see these two dots. These are the two dots of a balloon, and the balloon is in between. And then we expand the balloon, and this you can see the balloon expanding. You can see the balloon expanding. But the calcium chunk is so heavy that the balloon is not able to expand completely. And as we go to high pressures, the balloon bursts. It ruptures. So again, we are held in a situation where I'm not able to take anything inside because of this blockage, and it is a heavily calcified blockage. So now the only option that I have is to reassess it, and I take, this is the catheter, what we call as an intravascular ultrasound catheter, and this is how it looks inside the vessel now. So the vessel looks, this is what I'm showing you, this is the calcium chunk, the white, bright thing is the calcium chunk inside. And I have made some way, I've cut it a little bit, and it is like, this is how it looks. This is how, when I play it live, you can see the narrowing now, you can see it will narrow in between. This is the calcium chunk that you're seeing, the bright, this is the calcium chunk, which is preventing the balloon from expanding. So this is how it looks. This is called the intravascular ultrasound. It is just like an echo or the abdominal ultrasound, same technology, but it is delivered through a catheter-like probe, which is put inside the coronary artery, and we take an image like this. So now I have no option but to use another special kind of balloon. This is the cutting balloon, but again, this doesn't make way. So finally, I take the, you can see this final slide that I've taken this. These are the 2 points of the 2 stents, and I expand the stent, but the stent also doesn't expand completely at one point. There's a small neck. You can see the stent expanded completely here, but here it doesn't expand. Now, if I leave the stent like this, it is going to thrombose, because again, the part of metal will be protruding within the vessel, and the normal blood flowing through it, once it comes in contact with this metallic stent, it will start forming clots, and the whole vessel will shut down completely, and the patient has a massive heart attack and he dies. So I then finally take the help of the special balloon, which is called the lithotripsy, and I give the short waves, and you can see it will gradually expand and it will open up completely. Here it opens up, right. So you can see now the balloon has expanded completely. So the shock waves have actually broken the whole calcium, and after this is opened, now you can see beautifully how this opens up. Now you can see it. So the balloon has expanded completely now. And the stent has expanded completely. You can see now it is clearly, you can see it has expanded. So after this, I put in another stent, and I finally, we normally do intravascular ultrasound after deploying the stent to assess how well the stent has expanded. And you can see the stent has expanded beautifully. You can see the stent. This is the stent after it is implanted. You can see this is the border of the stent nicely. It should oppose with the wall. If it is hanging inside, means the stent hasn't expanded. So you need to further dilate it with a balloon. So this is a beautiful expansion. You can see it. And at the end, we just make a pullback and we come out. And the calcium is all nicely cut with all the various technologies that I have used, giving a very good result. And finally, this is the result. And I'm very happy. The patient goes home after 2 days and he has been under my follow-up. Now you can see how beautifully the whole thing has expanded now. This is the normal vessel. This is the normal vessel. It looks like a normal vessel after I've put the stent. This is another vessel which has blockages, but because of this being a very extensive procedure, so when you put in a lot of contrast, you try to prevent doing the other ones, because the more of contrast goes in, it is going to damage the kidneys. Usually it is reversible, but it can also sometimes become irreversible, and then the patient can go on to dialysis. So one has to be very, very careful of how much of contrast. So I had already pushed in about 300 milliliters of contrast, and I decided to call it a tray. Now, this is another device that you are seeing in below. This is called the intra-aortic balloon pump. This balloon pump actually gives support to the blood pressure of the heart, and it expands during the diastole. It's only during the diastole it will expand, and it is synchronized with the ECG. So it causes a certain amount of blood to rush into the heart during diastole, improving the flow. And since the patient was having severe left ventricular dysfunction, that means the heart wasn't contracting as much it was supposed to because of the blockages, multiple blockages. The normal ejection fraction is about 55-60%. This person had about 15 to 20%. So I used the intra-aortic balloon pump to support his heart. So you normally keep it for about 24 hours, maximum 48 to 72 hours, but this person required only 24. After 24 hours, we took the whole support off, and he made a very good recovery, and he went home. And he has been under my follow-up. This is another case, but it's again a very similar one. So after we finish the cases, which is very, very important, that we have to keep an eye on the groin, whether we close it with the device or not, because these patients are on blood thinners and they're going to remain on these antiplatelet drugs for at least 6 months to 1 year, and they can have bleedings. So it has to be compressed it has to be compressed properly so that the complete hemostasis is achieved. And after we check, we ask the patient to cough. And if he coughs, if there is any dislodgement of the clot, there will be a spurt of blood coming out. So again, we need to further compress it for maybe another 10 to 15 minutes. And we remove the sheath after checking the ACT. We maintain an ACT of about 300 during the procedure. And when we take the sheath out, usually we expect the ACT to come down to 130. In the meantime, if patient bleeds, we can use protamine injection, which can reverse the effect of heparin, and that causes the ACT to come down to a required level that we need for the sheath to take out safely and cause hemostasis there. Thank you very much for your kind attention. I think I will stop here. Any questions?
Hi, thank you, Doctor, for the beautiful presentation. There are a few questions that are posted in the chat box. The first one would be, is it possible for the balloon to rupture? And if yes, what would be the way forward?
Yes, the balloon can rupture. So the person who is preparing the balloon has to be sure of one thing, that he or she has to aspirate whatever air is there. Because if the balloon ruptures, it can cause some trauma. But if there is an air bubble in the balloon, that goes and it will cause an embolization and the whole circle, and that is no way out. But normally, if the balloon ruptures, nothing, you can take the balloon out. Only thing is that at high pressure, when it ruptures, the fluid inside the normal saline and the contrast in that causes a little injury to the vessel inside. But that can all be tackled with stenting. So this is what happens with the balloon rupture. Yes, next question.
Is it advisable to flash the vein with aqua when the vein is blocked?
I beg your pardon?
Is it advisable to flash the vein with aqua when the vein is blocked? I don't know.
No, it is. We don't flush it. I mean, normally we flush it with normal saline. We can do it with distilled water as well, because the contrast, once it dries up, it can actually block the. I have had such experience. because many a time we have to use the same balloon, and in the time when it is outside, these contrast media, they become dry and they become just like particles, solid particles. And when you just push in, it goes in, and when you try to deflate the balloon, it doesn't deflate. And that is one, I mean, hell of an experience that a person experiences. And because the balloon, if it remains inflated, again the person dies, because there will be no flow in that vessel. So we need to take a wire or something to rupture it. Or yes, we cannot, we normally inject only things which are safe, like a normal saline or a 5% dextrose or distilled water. We don't flush with anything. If it is blood, yes, we can, but otherwise we don't need actually a heparin.
Okay, there's another question. How can one perform vivisection successfully on someone who has anosarca and may also be going into shock?
Yes, of course. Of course.
Okay.
This is pretty common that we have that during the emergencies. When we do a primary angioplasty, the patient can have any form of arrhythmias and we need to cardiovert. There is a lot of instances where I think in the last 1 year, I've done at least about 10 cases where people, by the time they were wheeled in, because there is initially a resistance to accept that the person is having a myocardial infarction. And by the time they're prepared for the procedure, they have a cardiac arrest while they're being wheeled in, or right even at the emergency. So we continue the CPR, get the patient intubated, and while the CPR is going on, I've done a lot of procedures, keep on shocking repeatedly to bring back the rhythm. And once the circulation is re-established in the vessels, in the coronary vessels, they usually recover very well.
Doctor, thank you. That's all.
Asha, there is one question by Sandra Kumako, 542.
Okay, maybe you can read that.
Yeah, doctor, can I ask, when the vessel is past the fat or classified deposit, how are the removed from the circulation?
They are actually pulverized to microparticles, and it just goes through the circulation, through the blood, washes it off, and then it goes to the capillaries, and then through the veins it goes out. So it goes to microparticles, less than 7 nanometer particles.
One more last question, doctor, from Barbara Aniba. How can one prevent air in the veins, because before one pushes any medication or infusion, there is an amount of air already at the tip of the cannula?
Very good question. Very good question. You need to aspirate it, or else what you can do is you take the syringe out and let the blood come out, back bleed. That is what we call as back bleeding. And then with the syringe, you just get the what you call the bubble out. If you hold the syringe like this, the air is always at the tip. So you just push, the air will go up. And if it is right at the cannula tip, you take the syringe out and let the blood come out. It will get all the bubbles out. That is the best way. And we need to do it all the time, even while we have the catheters inside, because that is where you have the maximum chances of a bubble going in. So we let the back bleed. We allow the catheters to back bleed by opening the valve, what we call as a Tuhi burst. We just open it, and once the blood comes out, because the blood pressure is usually 110, 120, 130, that is good enough to get rid of the blood out. In a vein, it is different. In a vein, of course, in veins, small bubbles usually don't matter. But in an artery, every bubble matters. So in a vein, it is not so dangerous. But if there is a large bubble, it has to be taken out. Otherwise, it will go and get deposited into the pulmonary artery and cause a pulmonary embolism. So the best thing is to allow the blood to flow out. That is the best way to get rid of the bubble.
Thank you, Doctor. Arun, I think that's all from the Q&A session. Thank you, Doctor, for the very beautiful presentation. Huge thanks to Dr. Samanjoy Mukherjee. Huge thanks to Shani Varghese for organizing for today's sessions. And a word to all the delegates who have joined us today. So for getting your certificates, please access the link that is shared with you on the chat box. Thank you, Dr. Samanjoy. Thank you, Dr. Shani Varghese, one more time. And
Asha, ma'am can ask some questions. So, Purpuchal ma'am, she wants to talk to Dr. Samanjay.
ma'am, would you like to, do you have any questions for Dr. Samanjay?
Well, I don't have any questions for the two presenters. All I want to say is that we are grateful for the knowledge that has been shared, and I'm sure it will impact our practice in various ways. So we are grateful.
Thank you so much, ma'am. So thanks one more time to Madam Purpuchal for joining us and for supporting us for all through our sessions. Thanks once again, Dr. Samanjay. Thanks once again, and all the delegates who joined us today. Thanks from Manipal Hospitals, India, and hoping to catch up with you in the next session, which is going to be on on other important topics as well. And with this, we have come to the end of today's session. Hope this session has helped you to become better professionals and to contribute to patient health in your country. Thank you all once again. You have a great, amazing day ahead. Thank you so much.
Thank you too.
Thanks a lot for all your support, continued support, and we still grow bigger and stronger with your blessings and guidance. And
let's see your video. Show your video, Dr. Arun.
Sure.
So you were saying?
Ma'am, with your blessings and support, we will grow much bigger and stronger.
Okay, great.
So what is our next idea is to include more audience like physiotherapists, technicians, who are also part of the hospital group, right? Nursing plus physio plus technicians can be a part of this Master Medics Plus program.